Okay, thank you for asking me to come and talk about this. I've had the privilege, I think, of writing some recommended procedures that the BSA are about to publish. I ended up becoming part of the electrophysiology group, and how many people here do ABRs on older children? Yeah, there's quite a few people, and our centre do quite a lot of ABRs, and one of my suggestions was that we need a protocol to help us, because there are a lot of parameters that we can change based on the NHSP guidelines, but actually people need to know what's safe and what's practical to change. So unfortunately, sometimes if you have a good idea, you are the one that ends up solving it. So this protocol's probably been a year in the writing, so I'm going to run you through it. So it's going to be very practical, and you can start using some of these figures. The protocol has been reviewed by the Electrophysiology Special Interest Group. It's this week been submitted to the BSA Council, and it will go out on the 20th of November for a wider consultation. So look out for it. Please give me your feedback. It needs to be as practical as possible to help you guys with testing and seeing children. So I'm going to introduce you to the procedure and help you understand the rationale why we've chosen the parameters we've chosen. And there's also a section on neurological ABR that Guy Lightfoot has written. So I'll try and do that section justice, but it wasn't my section. Okay. So the NHSP did an excellent work in giving us some very good guidelines and helping us to establish consistent practice with ABR responses in babies. What do we do when we've picked up the babies from the newborn screen? We've got that excellent early audiological assessment and management of babies. And then we've got assessment and management of neuropathy babies as well. So all those still stand, and if you don't know, the NHSP no longer exists, so all the documents are now housed under the BSA website, so have a look, they're still there, and they're still current. But we felt we needed to address what happens post-newborn, so when your baby no longer sleeps quite as easily, or you're asked to go into theatre, or you're trying to do an ABR on a 2-year-old, and you've got very limited time. How can you manage to maximize your information and get as much as you can safely? And sometimes the NHSP guidelines don't actually allow you to collect enough information. So this protocol is about what can we change and actually keep the quality of the ABR safe. So sometimes we have to do ABR, but we should always endeavour to do a behavioural test. So the ABR might supplement your behavioural test, but you're still trying to get that PTA or the performance or the VRA or the distraction. But sometimes there's loads of developmental issues, cognitive, motor issues that make that very complicated. Sometimes children present with non-organic behaviour, and you need to actually find a definition for their hearing. And quite often a good place for that is the operating theatre. If they're going for a procedure, you might be able to piggyback on the back of that with consent and actually do an ABR. So if you don't have that set up within your hospital setting, try and make links and things like that. The guideline doesn't cover corticals because Guy Lightfoot has just written a brand new protocol which has already been published, and it doesn't cover steady state. That is covered a little bit in the early identification guideline, but it might be something we'll work on later. So this is what can you do and how can you do it safely. It does cover a little bit of sedation and anaesthetic. When we were looking into it, we were trying to define what was good sedation and general anaesthetic, but it just became a minefield. Every hospital has got a different protocol, a different procedure, and it was too complicated to list it. So I think you just need to work within your own hospital's criteria and do your testing, your ABR testing, and let the anaesthetist and the medical staff deal with the sedation and things like that. Because some centres require, even for sedation, a hospital bed, and other centres didn't. So I haven't really gone into a lot of detail on that. That would be up to you to have a look and look into it. And then the protocol covers neurological ABR. So we've tried to define what we mean by our different terms. So baby is up to 12 weeks, that's when the newborn screen is. So we're wanting you to use the NHSP guidelines. Infant we've defined from 3 to 24 months, child 2 to 16, and adult over 16. So we're hoping, well, the guideline covers infants onwards, okay. This is just the terms we've put on it. You might have different terms from a medical point of view, but this was just trying to define it within this protocol. And like I've said, the early identification and assessment of babies is still your gold standard, okay? So start with all your parameters set to the NHSP protocol, which is now housed on that BSA. But sometimes you'll find that you've got it all set to that and you're still not managing to get your ABR. So these are our requirements. We need all our equipment calibrated for clicks, tone pips, chirps, with AC and BC annually. It obviously has to go through your electrical testing, and you need just daily stage A checks. I would say that your staff do need to be an expert in being able to do ABRs. You need at least some person within your department who actually can take overall responsibility and make sure that the training and the level of competence of each staff meets the criteria. You don't want to be getting into situations where you're getting into trouble for poor traces. Oh, sorry. And actually, the BSA are in the process, we're in the process of doing a peer review document suggesting how you might like to do a peer review system. So within Yorkshire, we've got a regional group where we're meeting and we all submit anonymous traces, and we don't know who's reviews it, and it comes back. And if there's a discrepancy within 10 dB, then we send it further on. But hopefully there isn't. Hopefully people do agree within 10 dB, okay. And then you need to audit, you need to look at your service and keep using that evidence and audit your service. Look at your accommodation. There's lots of criteria that have come out specifically for paediatrics with commissioners making sure that you've got a paediatric-friendly service, your waiting room, whether you provide cots to go to sleep, that sort of thing, how long your appointment is. It's very important that you allow the parent to be with the child because of the distress it can cause the child. So I'll let you look up when the guideline comes out, all the references, but we have tried to reference a lot of the commissioning documents as well. The adults, Guy Lightfoot felt it was very important to have an intercom system or a CCTV system, especially because a lot of the adults will be your non-organics and it'll be medical legal cases. So if you can get that set up, it's brilliant because people will do all sorts to try and fail the test. And then you need to look at your communication before appointments. And there is a section, I've not gone into it today, about reporting, so how to report your ABRs and that sort of thing. Electrodes, we suggest high forehead for the infants, but then moving to the vertex for children and adults. It'll just make your wave 5 a lot bigger and easier to see. But it's up to you at the end of the day which you do, but that's what we're recommending. So we want you to start with the NHSP guidelines, that early assessment guideline, to have all the parameters set exactly the same. Start with 4 kilohertz, like they suggest, around 40-50 dBHL, test AC and BC, but actually, if it's an older child and you're trying to resolve what their hearing is, you have to look at your clinical question. What are you trying to answer? What is it that's most important about that session? You keep your artifact rejection at plus or minus 5 microvolts, and you're aiming for that signal to noise ratio of 3:1. So all those, and the correction factors still apply, but they've been put into the document as well, so that there's quite a lot of quick reference guides so that it'll be very practical in your clinic. So keep all these parameters. This is just taken from the document. You don't need to write it down. It's all on the website, but just keep it set up as it is. We tried to set a discharge criteria. I have been brave and put one in there, but it also depends on what your local criteria is and what your clinical question is. There was a lot of debate around this. But a child's sleep ability obviously gets harder the older they get, so you really need to be flexible with your appointments and try and get the best time possible for them. You want them asleep or very relaxed to reduce muscle activity. And the same with your adult, you want them to be very relaxed. So, like I've said, start with everything exactly the same. And even if you're rejecting some of your waveforms, don't worry. Keep going. If you're collecting something, keep going. Okay. It's at the point where you start rejecting the majority of your sweeps. Okay, so by that I mean over 50%, and you've got to make a decision then. Is it going to take you longer to keep your artifact rejection at plus or minus 5, or do you need to speed up a little bit? So it goes through good housekeeping. So check your impedances are below 5. I try as hard as I can to get my impedances of 1, especially in the operating theatre. It just helps you. Make sure they're equal as well. Don't have one ear slightly higher impedance than the other. Try and remove all your electrical interference, separate your cables, gather your electrodes together, twist them or plait them. It's a miracle cure sometimes. Just take time out and plait them. It will really help. And in the operating theatre, make sure the endotherm blanket is uncoupled. It's no good being off it. It needs to be completely uncoupled. They don't like it because they've got to find a different way of keeping the child warm, either by putting the temperature of the room up so you're all boiling, but it is better than nothing. If that fails and you're still struggling, put your notch noise filter on. It will only eliminate electrical noise, but it can be the difference between getting something and not getting something. And in the protocol, there is an example where I've run a trace without it and then trace with it. If that fails and you're still struggling, then start increasing your high-pass filter. Go from 30 to 50, and this will eliminate a little bit of your patient-generated noise. And hopefully this will allow you to keep your artifact rejection at plus or minus 5, and you can do 2,000 sweeps that way. However, if you're still rejecting all your sweeps, then you can start increasing your artifact rejection. If you do this, you really, really need to increase the number of sweeps you collect. This is taken from Lightfoot and Stevenson's paper, and it shows you a criteria, and I've put it in the protocol because I think it's quite a nice visual clue. You've just got to increase your sweep. So if you're starting to reject more than 10%, then you can think about increasing it to plus or minus 7 microvolts, but then you need to double your sweeps. In doubling your sweeps, it will take you double the amount of time. So that's what I was saying. Way up, are you going to get there quicker, keeping plus or minus 5, or do you need to increase it, but then you need to increase your sweeps? We've said the maximum to increase by is plus or minus 10. And then you need to be doing in the range of 4,000 to 8,000 sweeps, and then doing repeats to make sure that you're safe and it's a good quality ABR. You can start altering your gain. Your gain is normally at 240,000. If you needed, for some reason in theatre, to increase your artifact rejection to plus or minus 16, then you have to reduce your gain to 150,000. It's just the way the gain and the artifact rejection work. And you should try and use your Bayesian averaging just to help you decide on a statistical note, is that ABR there or not. If you don't know what that is, there is a document that the NHSP did that goes through that, so have a look at that. Okay, this is Guy's bit, so hopefully I'll do it justice. So the neurological test is what we call latency. So you're looking, you're not looking at threshold, you're looking to see the action potential in the nerve. So you use a very high stimulus, you use 80 dB NHL, and it's a click. So you're producing a good stimulus, you're producing a large response, and you're looking at the latencies of all the waves 1, 2, 3, 4, and 5. And you're comparing them, and the protocol goes through different examples, and you can use it to look at whether there's neuromas there, hydrocephaly, multiple sclerosis, and ANSD, and he's put lots of examples in. So don't think, it's a good reference guide. This is what one looks like if you've never done one. So you're trying to find where wave 1, 2, 3, 4, and 5. Can you see that as it comes? So there's 1, 3, 5. What we've tried to do as well is look through the literature, and we've got a table with adult norms and a table with pediatric norms. Now, it's always good practice to run your own norms. It's a bit easier with latencies, but we have put those tables in, and in Sheffield we have done our own norms, and they do match more or less with what's in the table. But I would recommend just getting 10 children with normal hearing, seeing if they'll like to sit for half an hour for you. They don't have to sit very still for this, and just running your own norms, and just check that they match what we've put in the document. Parameters, a time base of 10 milliseconds is fine because it's a really broad stimulus. In order to preserve recording wave 1, although you can go up to a repetition rate of 83 per second, you will lose seeing wave 1 if you do that. So you need to keep it below 20 seconds. And we've suggested 11.1 because that's not going to sync with your mains. So if you pick the wrong rate, you sometimes can sync with mains, and all you'll be collecting is mains. So we suggested 11.1. Your low pass filter actually can be quite high, so it's 3,000 because it's such a broad stimulus. You can set your low pass filter to that. Artifact rejection, no more than plus or minus 10. It's a lot easier to detect than the ABR, so we've just said not more than that. And again, you want repetitions, and you want 2,000 sweeps. And your electrodes are at the vertex, you want it at the top of the head. And it's really important that you get your two ears balanced. It's no good if one is 1 and the other one is 3. They actually both have to be the same for this. So make sure you give them a good scrub. The stimulus, there is, if you use a click that's not 100 microseconds, then there is calibration issues. So if you change that, just be really careful, because there are calibration issues, and he does go into it in the protocol, so have a read of it. Some systems allow you to do alternating condensation and rarefaction polarity. Keep it on. Rarefaction makes waves 1 and 4 bigger, and condensation makes wave 5 bigger. But if you keep it alternating, then if you did need to separate it out to verify, because you're not quite sure, then it allows you to do that. If you wanted to pick one, then that would be up to you. And the suggested intensity is 80 dB NHL. And then your vertical scale ratio is set like that. There are working examples throughout the whole document, and troubleshooting tables. The one question that I feel we wanted to address that we haven't properly addressed, and maybe people can help us do this, is we wanted to put in the document a statement about whether if you got 4 kilohertz tone pip on bone at 25 dB NHL, was that a hearing loss? EHL, sorry, was that a hearing loss? And Siobhan and I have spent hours, she spent more hours than I have, because there's no easy way of looking at ESP data. So we looked for 10 years worth of our data, and we took every child that failed the screen. We then went in individually and found out what their AC and BC levels were. And I think we had 100 children, and out of that, 25 children had a BC level of 25, sorry, so maybe a mild hearing loss. I've then looked all the children up to see, well, how did that equate to VRA, bone conduction, things like that. Unfortunately, about 12 out of the 25 children have DNA'd, been self-discharged. We've got no data on. 5 out of the 25 have got a sensorineural hearing loss, and the others are in that process of conductive, not conductive, mixed, not mixed. So I don't think we can answer the question. I think you just can't say. So I think a lot of places when we were chatting about it do a very, oh, don't worry, it'll be fine. And I'm not sure you can necessarily say that, but I equally don't think you can say, yeah, it's sensorineural. I would like anyone who would like to do an audit on their NHSP data, not that it's easy, if you could give us some more numbers, that would help. Because even if I got another 2 or 3 centres worth of numbers, because we're looking for a needle in a haystack, really, you're only going to have about 25 babies in 10 years, then we'll be able to address that question within the protocol a bit better. But it's out for consultation on the 25th of November, so please feed back to me anything that is glaringly obvious we've omitted or you'd like to see in it. We'd appreciate that. So I'd just like to say thank you to everybody who's had input, and obviously Guy Lightfoot's written part of the document, but there's been many other people, Siobhan, Inga, Amanda, Vivian, John, Carolina, Stephen and Reese, who have all contributed as well throughout the whole year's process. So I'd just like to thank them as well.
Thanks, Mel.